Good morning.
Good morning.
Good
Good
morning.
morning. Just for the sake of sound, I'm going to stay on mute because I have a very small human who might squeak and squawk.
Of course. Absolutely. Hello, everyone. Good morning. Oh, good to see some friendly faces here.
Good morning.
All right. Well, let's go ahead and get started. People will probably join for the next few minutes, but I'll just go ahead and start with introducing myself. My name is Nicole Hamburger. I use she, her pronouns. I am the Health Connect Networks Manager here at Swatch and for the Health Connect Hub. We are hosting a Q&A session this morning to talk about our funding opportunity right now. And we are recording this so that we can share this on the application site on our webpage. And we will structure this very loose, informal. You are welcome to come off mute to ask questions, but you can also put them in the chat. Mercedes is going to be monitoring the chat. She will stop us if it makes sense to stop and talk about it right then. Or we may just wait till the end. We will absolutely make sure we leave enough time to answer all of your questions at the end. So let's just go ahead and jump right in. I also have Basevi here with me. He's the Health Connect Operations Manager, and Morgan Middlestat, the Grants and Contracts Manager. So we will all be kind of chipping in to share as much information with you and clarity on this opportunity. All right, so the agenda is to share a little bit of context and information about Swatch and community care hubs in Washington, the funding opportunity and request for application overview and what that will look like, the contract workflow, and then enough time for anything that you have questions about. So just to get started, and so that we capture who's here, if you could put in the chat.
This meeting is being recorded.
Yes. Yes, it is. Yes, for those who just joined, this meeting is being recorded so that we can share the recording with folks who maybe weren't able to be here and to be on our website for folks to view while this RFA is open. But yeah, just go ahead and share in the chat your name, who you are, your role, your organization, so that we have some record of that. Okay, so we'll just jump right in. Swatch's mission. So we are dedicated to the pursuit of health equity by addressing the barriers that impact well-being in Clark, Klickitat, and Skamania counties. Through collaboration, innovation, and community partnerships, we drive sustainable solutions that promote health and wellness for all. So if you don't know much about accountable communities of health, that is okay. And we won't be going too deep into the functions of Swatch and the different programs that we offer. But you can see on the map here that Washington State has 9 accountable communities of health. So we all cover different regions, and our region here is the Southwest region, so hence the name Swatch. And our region is Clark, Skamania, and Klickitat counties. And we are funded primarily under the 1115 Medicaid waiver. We are now in the demonstration of Medicaid Transformation Project 2.0. That's the MTP 2.0. And under this waiver, the Centers for Medicare and Medicaid Services are funding health-related social needs. So that's kind of the driver into MTP 2.0 and some of the changes we've seen from 1.0 is this whole creation of health-related social needs to address social determinants of health. So HRSN, that's the acronym for health-related social needs. So you may hear us using that acronym. And the HRSN services address unmet adverse social conditions that contribute to poor health and poor health outcomes. So this includes things like food insecurity, housing instability, unemployment, lack of unreliable transportation, all the things that a community-based care coordinator would be supporting individuals and families with getting connected to in their communities. So MTP 2.0 is requiring that all ACHs, accountable communities of health, develop and sustain a community care hub model. So this is, again, the next phase of this demonstration waiver is that we are all, coming together as the community care hubs of Washington. That's this logo here that you'll see. And it's pretty exciting. Fortunately, Swatch developed a hub model from the very beginning. And so we're just really looking forward to the next phase of this new model and this expansion. So, really excited about what's to come. But the community care hubs of Washington, the idea here is that they are providing free, low barrier, community-based care coordination services to increase access to needed services. Overall idea here is reduce cost, right? Reduce health cost, improve social determinants of health in our communities. So community care hubs of Washington amplify and coordinate the great work of established local community-based organizations. We connect these trusted organizations with administrative coordination, funding, training, and tools so that they can offer the culturally appropriate and linguistic one-on-one support from a community-based workforce. The goal is for us to be taking some of that administrative burden off of the community-based organizations and support a coordinated effort, a no wrong door approach for community members to be able to access these services no matter what door that they walk into. Another reason why expanding our network and our partners is really exciting for us. We do want to grow our partners and be able to provide more access for community members. Okay. So whole person care is like the higher level, bigger idea that we are trying to address, right? We know that, folks accessing the emergency room or urgent cares or, with hospital, with needs for being admitted to the hospital, things like that drive healthcare cost. Medical needs are only a small percentage of the risks that is impacting someone's overall health, and social drivers can really make up a big chunk of someone's overall health and well-being. So the concept of whole person care is recognizing that the best way to care for people with complex needs is to consider their full spectrum of needs: medical, behavioral, social, socioeconomic, and beyond. The way that, we do this is through the work of community health workers. So community-based care coordinator is the, official term that we use statewide when we're talking about this model and this program. But they have different titles. You will hear of them having different titles, such as community health worker, peer support specialists, care navigators, things like that. So that's all talking about the central role that they play as frontline trusted workers, supporting community members, supporting their communities, and building trust that way. They build trust and provide culturally responsive support, connecting community members to resources that meet their needs. We value lived experience of this. Sometimes this lived experience includes, experience with conditions themselves. It could include, you know, the in-depth knowledge and experience of navigating these systems. So there's many different ways that lived experience comes into play here with community health workers, that allows them to, build trust in their communities. So they help community members navigate these systems, and provide that one-on-one support. So the idea of the hub here is, we receive referrals from all different sources. Our partners receive referrals, obviously folks walking through their doors. It is a coordinated response. So referrals come in many different ways, for patients or clients with complex needs, who are referred to the hub. And the idea of a hub is not like a physical place. It is the network of community health workers. It is the technology that they will be documenting in, such as the community health record, and the hub infrastructure that includes the support that we provide to the contracted partners, to our partners, and taking off some of that administrative burden, providing the training, providing the workflows, and the technology. And then, the community-based organizations receive those referrals. They assign to the right community health worker who will then coordinate with the community member to address physical, behavioral, social needs. So this just shows right now, from our current contracting period, these are our current partners. In Clark County, we have Child and Adolescent Clinic, Lifeline Connections, Lutheran Community Services Northwest, Outsiders Inn, CMAR Community Health Centers, Share, and Vancouver Housing Authority. And in Skamania County, we have Skamania County Community Health. And in Klickitat County, we have Washington Gorge Action Programs, also known as WAGAP. All right. So this funding opportunity is referring to becoming a partner under our navigation program. So this is, at the higher level here, this is health-related social needs case management. This is, funded under, again, MTP 2.0, with the Healthcare Authority. And the navigation program is designed to assist people no matter how or where they first seek help, screen for and connect to services for health-related social needs, focus on client-centered care coordination. Community health workers help community members engage with health and human services, meant to be equity-centered, low barrier, and grounded in dignity and community trust. And what we mean by low barrier is, there is no eligibility. We talk about, this being funded under Medicaid, and, the Medicaid Transformation Project. But this program does not have eligibility just for folks on Medicaid. Folks can have private insurance, they can be uninsured, they can be undocumented, right? So it is low barrier. We don't have eligibility other than they need to reside in our region of Clark, Skamania, and Klickitat counties. And they need to have full autonomy so that they can consent to participate. This is a voluntary program, so it's centered around families. However, the client itself needs to be able to have full autonomy and to be able to consent to the program. The navigation program, we expect a caseload size of around 40 to 50 people. This is for folks who are familiar with our current Pathways program, this is a lighter touch model. It will be, less about full assessments, right, of these complex needs and care planning and establishing goals. And this is really just, a lighter documentation model. where, they will be screened for, their social, health, medical, and behavioral needs, and then, connection to those needs. And those are the things that will be documented in the community health record. We expect episodes of care around 6 months or less. And our priority populations, for right now, for this program and for expansion of our partners is youth. So this could be up to 24 years old, and the reentry population. So folks who are leaving incarceration. The funding opportunity,
Nicole,
yeah.
can I pause you? There's a question about client eligibility. Does the client need to be uh need to have legal status to be eligible for services?
Nope. No, they do not. We don't ask those questions. We don't ask, in our screening and assessments, uh, someone's legal status, someone's citizenship status, someone's social security number. We try to ensure that our assessments and screenings, are really just to collect the information needed to support the community health worker supporting the community member. It may be helpful for, the community health worker to know that, but as far as documenting into the system, we do not ask for that. Okay, so the opportunity funds community health workers and a supervisor time to deliver the care coordination services. Organizations need to maintain appropriate supervision and staffing structures to support the contracted navigation care coordinator positions. Funding is awarded through this navigation program. Contracting period will be primarily issued as a cost reimbursement service contract to support the delivery of navigation services. Selected organizations will be required to use Swatch's client management system to document client interactions, to track referrals, and report the outcomes. So documenting the connections to the services and the outcomes of those connections. And then selected organizations must comply with Swatch's data sharing, documentation, and reporting requirements. And so some may also be wondering, so what does the hub provide? I've talked about this a little bit, but the concrete answers are the HealthConnect hub is providing the funding, so the cost reimbursement for navigation staff, CHW, and supervisor FTE, direct program costs, and prospective deliverable-based funds. So there is going to be which we're going to get into, but there is going to be a period before the service contract where we are supporting a capacity building period. We are supporting organizations to make sure that they have the infrastructure to be able to stand up this program. We provide all training related to this program and beyond. Our community engagement team provides additional trainings that is open to the network and open to the workforce. That may be how you know about us, the HealthConnect Hub, right? Is the community engagement team providing trainings that are open to the community, events and celebrations and many networking opportunities, right? We know that community health workers thrive when they are really connected to the community-based workforce. They have direct connections with other partners and other agencies to help support their clients getting connected to other services. We provide ongoing and consistent technical assistance. We have weekly office hours. We have cohort trainings. We provide on-site site visits with agencies, refresher trainings, and all of that at the agency's request. We are really responsive to training needs. And the networking piece, being a part of a network of a no wrong door, is really providing a platform for community members to be able to access the services they need in a much more streamlined way. And so again, the networking piece here is something we always strive to provide in every possible way. Okay, so now I'm going to pass it off to Basebi to talk about the RFA timeline.
Yes, good morning. Again, my name is Basevi Adamo. I'm the HealthConnect Operations Manager at Swatch. So thank you all for being here. We know you all are super busy, and we hope this is communicated as clearly as possible, and making sure that y'all get back to have such a wonderful impact on the community. When we talked about the navigation program and timeline in February, we did the funding announcement, and then March, the RFA, the request for application, became available, and here we are at the Q&A session. The period for the RFA closes on March 20th, so it's 2 weeks away. And that is submitted either by Jot form or by Microsoft Word if you download the actual whole request for application. But we think the Jot form, and we've seen some applications come through already, so we appreciate those of you who have submitted that. We will review those over the 2 weeks following March 20th. And the request for proposal portion of the contract opens April 13th. And so that is by invite only. And we will let agencies know whether they've been approved to move to the request for proposal portion of this timeline, or if they are, we want to remain friends. There is a good question in the chat from, and I may be butchering this name, Lucian, about resources and what else they can do to support parents that are serving, struggling child support obligations through organized communities. And I think that's a great question, and I'd like to answer it a little bit later. But we do a lot of different things. I think Nicole did a great job of going over that. So, sorry, back to the timeline here. So the request for proposal will have a question and answer session similar to today. The request for proposal will be far more in depth compared to the RFA. The RFA is meant to be more of a screening process to make sure that you meet some minimum qualifications to partner with us, because we are funded through the Washington State Healthcare Authority. There's a lot of the devil's in the details with all of this stuff, and we want to make sure you're meeting the minimum requirements and not wasting your time before moving to the request for proposal portion. For those invited to the request for proposal, it will be due May 1st, and then we will go through an internal RFP scoring process. We're working on weighting those measures now, but we also take the request for proposal to our HealthConnect Advisory Council to try to get as many voices. It's a lot of different people from the community that do this work, and then also some community members coming together to help us and guide us as we develop these programs to make sure that we're hitting the right mark. So that's the RFP scoring side of it. And then agencies that are approved to move forward into the navigation program formally would know by the end of May, on May 29th. And then we would issue a draft contract on June 5th, and then go through another question and answer session for that contract. I do want to also point out that we are available for any one-on-one meetings throughout this whole process. We know this can be kind of maybe overwhelming depending on where your agency is and what your familiarity is with these processes and going through the application process. So you can always email us or contact us, and we can do one-on-one meetings. We are going to finish up here a little bit early, so there's going to be a good amount of time to answer questions. When we talk about the actual contract, it runs July 1st of 2026 through the end of June 30th, 2027. So it is a year-long contract. The first 3 months are what's called a capacity building period, and we'll dive into a little bit more of that later. But that allows agencies to essentially get ready to run the program. We don't expect agencies on this call or applying agencies to be immediately ready to have community health workers serving and have an internal workflow and all of that set up on day one. We are here to help you and assist you through that process, but it is a 3-month portion of the contract, up to 3-month portion. If an agency is ready to go into providing those services at any time from July 1st, we can accommodate that. And I'm going to go to the next slide here. All right, so this kind of lays it out a little bit more visually. So we're in the RFA portion right now, and then it'll be invite only for the request for proposal. The actual contract is developed in two phases. That capacity building portion is the master service agreement of that. And then the service contract, which would be the next 9 months of the contract, will be an amendment. And so the first 25% of the funds are they're deliverable based payments. So complete to sign the contract, 5% of the funds are there. Complete training for CHWs, another percentage of the funds, but up to 25% is within that master service agreement. And then agencies that are ready to move forward into phase 2 and deliver services, that becomes an amendment, and that where the 75% of funds are through monthly invoice reimbursement based payments. So we want to make sure agencies are obviously ready to move into phase 2. We are pretty intensely would work with partners in this agency or partners within the navigation program, and especially new partners to us to help them hire CHWs and or the supervisor, complete the trainings and onboarding, develop internal referral workflows if that's something that's new to what your agency is dealing with every day. There's some admin onboarding and certainly integration of finance and making sure that you understand the invoice process. And then tech readiness is always something of concern, right? Making sure that the proper security, making sure that we're meeting the local, state, and federal regulations when it comes to security and client privacy. Are there any questions on this slide? Just as we hover here for a minute before we dive a little bit deeper into this contract. You feel free to come off mute. Okay. They do not. So the question in the chat is, do CHW needs to be new hires? They do not. They can be transferred over from another department. Or our main concern is singular funding source. So if we're funding a CHW or a supervisor at agency, that it's not getting duplicated by another grant or another funding source within the agency. We have a lot of restrictions on that with our how we're funded through the Washington State Healthcare Authority and how that pass-through funding works. The agencies are ultimate. So the question is, do CHWs belong to the agency or Swatch? And who hires them? Can you use a third-party agency? What is the plan for financial support after the 6-month delivery period? So the CHWs, the supervisor, belong to your agency. You hire them, and you are ultimately the ones holding them accountable. We provide training and we provide support. But I do want to be clear that the CHWs and the supervisors are hired by your agency within the request for proposal portion of this contract. So like here, there'll be a pretty heavy budget portion, which will outline, how much support you need. Yes, this is a fully funded FTE, full-time equivalent for those community health workers. And we went a little bit in the RFA, but this is up to 2 CHWs per agency and typically it's about 0.2 supervisorial time to cover that. There's the other portion of that question, can we use a third-party agency? I do not know off the top of my head, and I'd like to get back to you on that. And then financial support. So the capacity building, the whole contract is funded. We do 25% of the funding up front for the capacity building portion. And then if an agency is ready to move to the service contract, which would be the remaining 9 months of the contract, that is funded as well, reimbursement based.
Deanna has a question.
Yeah, please.
Hi, good morning. Thank you. In terms of the tech readiness, specifically in the space of cybersecurity, My understanding, based on what you've already shared, is that Swatch will be providing, will be helping the agency complete that readiness requirement. As we probably all know on this call, there are just so many different software applications as it relates to cybersecurity. Will Swatch either A, make a list of recommended software, a list of cybersecurity platforms that would be in compliance within the master service agreement, or would Swatch then kind of like preload like a, for lack of better words, a suitcase of software platforms for agencies that are in this space of building capacity and saying, these are the cybersecurity platforms that we recommend you move forward as part of fulfilling the master service agreement.
I'm gonna defer to my boss, Michelle Ahmed, the director of HealthConnect. She's got a much better pulse on it when it comes to tech readiness.
Our chief compliance.
Our chief
Yeah,
compliance
right.
officer as well.
Yeah, so I guess the simple answer is I don't know if we've covered this yet or not, but the documentation requirements for the program require using our system, which is Care Coordination Services. And that system, the login is secure, the system is secure, it's over the internet. So there's no extra thing that's required. Extra software. Most needs can be met through just kind of regular, regularly available Office 365 or Microsoft Windows. It's a matter of maybe having the right settings, like making sure people have MFA or log, and those things can usually be set up within what is currently existing in kind of normal software. When we talk about security requirements, our concerns oftentimes are around device management. So making sure that employees have the issued devices from the agency aren't using their own personal devices. That an agency has a way to check in and check out devices. So if somebody leaves, you're able to get that device back. Those kinds of things. So device management is more important than having it's a specific kind of cybersecurity platform. I mean, we'll probably ask you if you have virus protection, if you've got login set up, do you have policies around checking, around how employees use their devices. And then those policies and procedures we would provide templates for if you don't currently have them. And also, if, for example, employees are sharing devices, something like that currently as part of that capacity period that's deliverable based, those funds are not restricted to what you spend them on. So you would be able to buy devices for community-based workers if you need to and don't have ones that currently fit them. So
Thank you so much, Michelle. That provided a lot of clarity.
I see a question from Adrian Burris.
Yeah, I have a
Or hand
question.
up.
So it's around certifications. I think it was last July there were some changes made to the process for CPSSs, and that's the peer group that I'm speaking to specifically. So my organization specifically came from Oregon. I've worked in the peer field for quite a while. I've noticed that application process, the training, passing the exams, no problem. The application process can be laggy. Are you guys requiring that people have gone through that application process in its entirety to
For the
provide services?
for the peer support specialist license, is that what you're referring to?
Yes.
Yes. No, we do not require licenses of any kind. Community health workers in general aren't
Hmm.
aren't as certified. role in Washington State as of now either. And so, we are not requiring or looking at, licenses or certifications, things like that. Though many of our partners, are peer-based, peer-led organizations, so the agency itself may have different requirements, which is great. Obviously we love peer-led organizations, so yeah, we ourselves do not require licenses.
Okay, yeah, because it was my understanding in the state of Washington, unless you're billing Medicaid directly, that kind of changes the story. So, okay, thanks, Nicole.
Are there any other questions in the chat right now related to this slide, or should we move to the next?
It's not related to this slide, but it is a good question, and there's several in there. So the question is at the start: can we continue to work within our organization scope of service demographic? In their case, which is working with young adults 18 to 35 who are experiencing substance use disorder, or will be receiving referrals from other places. So we work with organizations that ultimately we're trying to leverage what you do best, what your bread and butter is. And so in that case, if you were chosen to be a part of the navigation program, you would continue to work with them, and we would find internally good candidates that would make a good fit for the navigation program. By being a part of the hub, and what Nicole went over a lot at the beginning, talking about the hub model, is that we're kind of like overseeing a little bit of we do a lot of systems-based public health, right? And so we're constantly keeping a pulse on what agencies are at capacity and what agencies have capacity, and where somebody might be a best fit, like wherever somebody comes in through the no wrong door, whether it's reentry or whether they're going to see their counselor, that they're able to receive services. So we, as participating in the navigation program, yes, you are agreeing to take referrals. Our job and our referral and system specialists do their best to assign referrals that would be appropriate for your agency, and that would be a best fit. So we're hoping to add to what your agency already does, and finding partners that best fit that situation. Is there any of my coworkers who'd like to add to that? Because I work with a lot of people I like to highlight.
Yeah, so when the hub receives a referral, we use a SMART assignment approach where we are looking at what language does the community member speak, right? What cultural alignment do they have with our current network and our current CHWs? What are their biggest needs? If they are a youth or young adult needing substance use disorder services and treatment, your agency may be a better fit, right? We're going to try to pair, the community member with the agency out of our, current network that is best meeting the needs of the referral. And so we do that to the best of our ability, and beyond that, we are, very flexible with agencies and where they're at, if they are at a capacity for accepting new referrals and things like that. But we do, hope that, agencies are, able to take referrals from the hub and not just from their own organization, if that makes sense.
The next question in that message is: are we able to conduct outreach to targeted population? 100%. Yes, we hope. We hope you continue to do targeted outreach and reach populations. Huge part of this work. We're always trying to help agencies do that if we can, whether it's creating flyers or producing some swag that y'all can take to events. So yes. Can the CHW float around? Sorry, just taking the next question here. Can CHW float around and support other clients we serve within the organization? Is it okay to have the supervisor of the program supervise additional programs within the organization? So I'll take the supervisor one first. Yes, it is okay for the supervisor to supervise other programs within the organization. This navigation program is going to come with 0.2 supervisor FTE. And so that's 8 hours of coverage per week to support up to 2 CHWs within an agency. So yes, yeah, it will, to supplement that, the rest of the 0.8 of that supervisor FTE, it would be, makes sense. And can the CHW float around and support other clients we serve within the organization? Yes, and we hope that there's internal referrals, constantly communicated to throughout an organization. Our main concern comes from like a funding perspective, is like if there's a 1 FTE of coverage for a CHW within the navigation program, that it's not being duplicated payment from another grant. So that's really that can kind of be answered. Did I answer that question to Mina Gilson? Is that kind of, do you have any other questions? Yeah.
No other questions. Thank you for going through that laundry list of questions.
Yeah, no, it's good. It's good. Okay. We got another question. I've already established connections with Reentry Navigation Division program and soon going to help people released with child support. If I'm patented up with you, can I refer to them to you as well? Yes. So we do act as this is a two-way street. So if you have additional capacity that you're unable to serve, then yes, we encourage you to send those referrals, and we can help to assign them to different agencies that would be a best fit within our pre-existing programs, within the HealthConnect hub, within the community care hub. So yes, and I do want to say, like, beyond just the navigation program, that there is always an ability to self-refer to clients. We're always looking for more referral sources. So that's kind of a broader point beyond just navigation, but yeah, definitely a two-way referral street. And 15% indirect. I am going to defer to the contracts and grants manager for that next question. I believe it's related to like how much you can invoice for on a contract. So I'm going to reach out to my coworker Morgan Middlestat, who is the contracts and grants manager.
Hello, thank you, Basevi. And I just want to make sure I'm getting the question. Okay, so for the 15% indirect, I will actually just have to check with our director of finance and send a follow-up for this. We did do 15% indirect when we were using federal funding for this grant that had that we were a subrecipient of, because that's as of 2024, I believe October, that was the increased rate for federal contracts. So I believe, and of course it will also depend on what your agency currently has as their indirect rate, whether that's like a negotiated rate. I know some of our agencies have higher, and then we're able to accept that because that's your NCRA, your federally negotiated rate. So let me check on that, and I'll get back to everyone and send a follow-up like when this is sent out, just so I can get the exact number. Typically, we do 10%. We do follow what our funding outlines as well. So just with this new contract, I just want to make sure I'm giving the correct information. So yeah, sorry, don't have a straight answer, but I'll make sure I get you one.
All right. I see one other question in the chat. I'm just going to move it to a little bit later, and I'm hoping these next couple of slides help answer that. So diving in a little bit deeper to the phase 1 capacity building portion of the contract. And so these are the first 3 months of the contract: July, August, and September. And the goal is to get agencies ready to move into actually providing services. So we work really closely with agencies at the beginning section of this. We're really trying to ensure the agencies are fully prepared to deliver high quality navigation services before full service activation. So that would cover staffing and supervision readiness, training and onboarding, data system integration, operational alignment with HRSN Medicaid waiver requirements, establishing internal workflows and compliance structures. I want to call out data system integration. So our community health record is kind of similar to electronic health record. Our community health record, or CHR, is called Care Coordination Systems. So as part of this program, the community health worker and the supervisor would have access to that platform. And you do have to use the platform that we have, Care Coordination Systems, or CCS, as part of this. And so really we're trying to train the supervisor and the CHWs on that to make sure they feel comfortable using that system. We use a community health record as opposed to like an electronic health record, which may be like Epic. If you go to like a doctor's office, a community health record is really focused on, we're trying to document outcomes. It's a system that can be used across all of these partners. So your agency is only going to be able to see your agency's people, but we can assign other agencies. Like if there's a referral, then we can assign it to you. So everybody is kind of seamlessly integrated into the system. And so we want to make sure that your agency feels comfortable using that system, that the community health workers have the support to do their job every day. Any questions? Any questions there before we look at phase 2?
We should also maybe mention that, if agencies are really set up and, have the infrastructure and are ready to go, you do not need to sit around waiting for that capacity building period. And we will go ahead and get you trained and get you started. So just also wanted to call that out, that this period is really just going to be intentional with where every agency and new partner is at. If you're ready to go sooner, then we will get you started sooner. Okay, so yep, you're gonna go.
Yeah, sure. So phase 2, this would be at the minimum the last three quarters or 9 months of the contract. So October of 2026 through June 30th of 2027. To move into phase 2, it's an amendment to what would be the master service agreement, and that's where the 75% of remaining reimbursement-based funds would be available to agencies. Really, we want to make sure that you're operationally ready to move forward with that and delivering services, because a 40 to 50 person caseload for community health workers is a lot. It's a lot for anybody. So we want to make sure that your community health workers and that your supervisor feel confident to deliver that level of services. And we also have no expectation that you would have that immediate caseload right off the bat. Our plan day one is not to send you 40 to 50 referrals that you can enroll on that day and never sleep again. But it's a process over time, and we try to. That's really where that third bullet there on phase 2, continuous quality improvement. We do a lot of reporting. We like to make sure that agencies feel supported, and that what is going on with their community health workers every day is reflected in, as much as we can, like easy to absorb reporting, that you can make actionable changes to the program based off the reporting that we're providing. And so phase 2 is an ongoing service delivery, and it's an ongoing quality improvement process. We continue to provide trainings. The cohort, we haven't talked about quite as much, but it is a monthly cohort. It's a monthly meeting with navigation and pathways partners or other partners. But there's also a greater HealthConnect cohort, and that is agencies that may or may not be partnered with us formally, but they're also coming together. Many of you on this call already attend the monthly cohort, the HealthConnect cohort, and you learn about resources and you get trainings from there, and you talk with your fellow colleagues within the nonprofit and the government world of our Clark County or Skamania or Klickitat County, and you learn about resources. And I think that's something that we do really well. Definitely commend my coworkers as they develop those trainings and those bring partners to the tables. And we really focus on trying to bring the most relevant resources to you, which it's housing, it's food, it's transportation, it's all of those things that are in dire need within our community. And so we're trying to, that's what the cohort, when we refer to that, is there's both the specific to the program, and then there's more broadly to the network. So phase 2, we're really trying to focus on program quality, Medicaid compliance. That is one of our, that's our main funder through the Washington State Healthcare Authority, and making sure that we're aligned with our funder requirements. And we want to make sure you have the strong infrastructure before the service expansion, and of course the responsible stewardship of public funds. Right, we're taxpayer funded. It comes through a couple different agencies before it gets to us, but we are taxpayer funded. As the accountable community of health, says it, we're always
we want to be accountable.
Community. That's right. That's right. So part of that cohort, that monthly cohort that I was talking to a little bit earlier ago, is really an opportunity, whether you partner with us or not, to continue to be a part of our network. It might not be in a formal contract relationship ways, but you can meet with us and meet with many partners, and network and be a part of the community we have here, and that we've spent a long time building to learn about resources and engage with fellow colleagues. Let me get off my soapbox here.
Mercedes, have you been keeping track of questions to make sure we're not missing any from earlier?
Yes, you guys have answered most of them. I think our last question started with Tabby.
Okay, great. Will there be future year funding opportunities to sustain these positions we invest in, or will organization sustainability plans be required? So we don't anticipate any changes, year per year, but we do, only do a year contract in case we do need to anticipate changes coming from our primary funder. And those may just be like subtle differences. Our current partners who have been, part of the program for a while now, have seen very little changes year after year. So we really try to maintain consistency there. But we do have found that, a year-based contract, just works out better in case we do need to make, adjustments here. I don't know if you have anything to add to that, Basevi.
No, I agree. We hear from partners, we hear from community that they want longer contracts. And the truth is we don't have that sort of predictability when it comes to policy from our funder to make that kind of extension. So I would also love, as we write these and we transition partners, to have a 2-year or multiple year contract, and to be able to say like sustainable funding is going to be for the next 5 years. It's just not a reality of the situation we're in, but we try to be as communicative to our partners as possible. So I would say, sustainability plan is an important part of this. We can guarantee for the next year of this contract that is fully funded, and we try to communicate as frequently as often as updates come down, and the contract may change, or the funding may change.
Michelle, I may have you respond to this question. I deal with highly sensitive information with child support cases. Can your system be modified to support how I deal with these, or should I just keep everything separate?
The short answer is I'm just going to guess, but I don't think it can be modified. The system is what they call a community health record system. So that means that the record has the possibility, if a client moves, for example, starts in one agency and then maybe moves their episode of care or is referred to another agency. Not that we're forcing it, it's just, part of how community members are served in the community. Then it's a possibility that record would be viewable by another agency. So if for agencies that, for example, are clinics or behavioral health agencies, what they do is they get consent to put information in first, but the information that is in the system is, one, viewable by the hub staff, and then 2, could possibly, with consent, be viewable by a different agency. Hope that answered the question.
Thank you. Is a mentorship organization eligible if our service base is restricted to one school campus and I'm getting feedback and open to the general public and not open to the general public? And is a 40 plus caseload the minimum? So yes, it is the minimum per CHW, per agency. So that would basically be, I think the biggest probably concern is that if your organization wouldn't be able to provide a 40-person caseload. Let me just
Can I jump in here
yeah.
too? Is that the 40 to 50 person caseload is the high end of that? That's 100% max capacity. We know it's not realistic for case workers to work at 100% capacity. Typically, in our Pathways program, the caseload is 25. We do a scoring, but we consider a full caseload 80% of that. So it does leave room for emergency type situations where we might receive a lot of referrals, but we have no expectation that a community health worker maintain absolute 100% caseload the entire time. So I do want to say that the question about not being open to the general public is an interesting one. Do you mind staying on after this? Because I do want to talk about a little bit about the bilateral referral workflow and that referrals and then also sending them to us as maybe your capacity is. So I just kind of want to understand your situation a little bit more, Claire Olmstead, and if you wouldn't mind staying on stay after class. Just kidding. If you're able to. If not, I'll see you follow up with an email.
Tabby asked, if new funding becomes available next year, are we expected to reapply through the same process each year, or will organizations that receive the funding one year be fast-tracked for additional years? Great question.
What we've done historically with programs is having a fast-track process for current partners. Our big consideration when it comes to that is the agency within good standing as we look at holistically at that agency, right? Are they experiencing a lot of high community health worker turnover? Are they serving the priority populations that we're hoping they do? Is their documentation adequate? And we have really clear kind of benchmarks about what that would look like. So historically, yes, we've had a fast track for current partners that are within good standing. But we want to make sure this is a relationship that works best for both parties and that we're meeting our funder requirements, especially when it comes to documentation and caseload requirements.
Does FTE cover benefits for the employee or salary only?
Yes, it does cover benefits, but we have no control over what you pay your community health workers. So we would love to put in a floor when it comes to paying community health workers. But ultimately it's up to your agency. So we cover an amount that is typically proportional to cover salary and benefits. But ultimately they're your employees and you pay them what you seem fair. We work with a lot of different agencies. And so, some agencies are in a union and that could be very restricted. And there's just a lot of different situations that could arise. But our goal is to pay enough to cover salary and benefits. Okay.
Any other questions? Yeah, I think we have, answered everything in the chat right now, but would just like to open the floor.
There's a cap question.
What is the cap per FTE?
Actually, don't remember it. Morgan, do you?
The cap per
yeah, the cap of the cost of the FTE.
I don't remember, and I don't know if it's been adjusted now since the last time we've done an RFP with the cost of living for over the 2 years. But we'll definitely have all this kind of squared away by the time we get.
I can tell you most agencies do not get to the cap, so the cap is fairly generous. I just don't remember what it is. Yeah.
Yeah, I could do some digging around for what it was in 2024, but I don't think it would, be the
Yeah.
same in 2026.
Yeah.
Yeah.
Any other questions before we close?
Morgan, will you be sharing that out when you find it?
For 2024, absolutely. I can share that.
Okay.
Okay. Well, thank you all so much for being here. Again, if questions pop up down the road, please don't hesitate to reach out to us. I will put our emails in the chat, and we hope to, hear from you soon and here to support however we can during this process. Thank you all so much for being here.
Thank you.
You.
Thank you.
Thanks, Nicole. It's so good to see your face.
Thank you, Tabby.